Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to the Solid Anatomy lecture on the foot. Now, it's entirely possible that you've experienced the entire series of Solid Anatomy lectures and saved the foot for the last, since it's the most inferior section of the body. If so, you'll probably be relieved to hear that there are only 23 muscles left to learn about. In the Solid Anatomy lecture on the leg, we learned about 4 of those 23 muscles already. So that's right, 23 muscles attached to and act on the toes. If you count the 7 interossei and the 4 lumbricals separately. If you don't, then it's 15 muscles, which is still probably surprising if you're thinking to yourself, my toes generally just sit around on my shoes all day and do nothing. Why would I need so many muscles acting on them? Now, the foot is nearly as potentially prehensile and dexterous as the hand, with one notable exception, opposition. But most of us have chosen to ignore that potential and live our lives as though our feet are just a pair of slippers articulating with legs. So in this lecture, we'll learn about the bones, ligaments, tendons, nerve supply, and blood supply to the foot. Now, I'll be back later for a clinical correlation and the end of session quiz. But for now, I'm going to turn it over to our primary lecturer, Dr. John Phelan.
The skeleton of the foot is similar to the skeleton of the hand. Instead of carpal bones, we have 7 tarsal bones. The calcaneus is the bone of the heel. The talus sits atop the calcaneus and articulates with the tibia and fibula to form the ankle joint. Talus is Latin for ankle. The navicular articulates with the head of the talus and is named after the Latin word for little boat, which it resembles. Anterior to the calcaneus and lateral to the navicular is the 6-sided cuboid. Anterior to the navicular are the 3 cuneiforms, numbered 1 to 3 from medial to lateral. Cuneiform is Latin for wedge-shaped, which describes the shape of these bones. The cuneiforms and cuboid articulate anteriorly with the 5 metatarsals, which are comparable to the metacarpals in the hand. And the same number of phalanges are found in the foot as were found in the hand, 14, 2 in the hallux, and 3 each in digits 2 through 5. Perhaps you're wondering why humans have a segmented foot rather than a single foot bone. A single foot bone would be effective at supporting body weight, and if some plantar flexors are present, a single foot bone would be effective at propelling the body forward during locomotion. What then might be some advantages of having a segmented foot instead of a single foot bone? If you choose an uneven surface for locomotion, a flexible segmented foot would be better able to conform to the uneven surface than would a single foot bone. Another consideration is that the foot has to support the entire weight of the body and withstand large forces during running and jumping. A foot consisting of segments connected and supported by elastic ligaments and tendons would be better at shock absorption than a single foot bone. Also, multiple muscles crossing multiple joints in a segmented foot would be able to generate more propulsive force than would be available with a single foot bone. A segmented structure, however, is only able to bear weight if the segments are arranged in the form of an arch. No surprise, then, that there are 3 arches in the foot. The medial longitudinal arch is made up of the calcaneus, the talus, all 3 cuneiforms, and the medial 3 metatarsals. The lateral longitudinal arch is formed by the calcaneus, the cuboid, and the lateral 2 metatarsals. There is also a transverse arch consisting of the 3 cuneiforms, the cuboid, the navicular, and all of the metatarsals. These bones form half of an arch that is completed by the opposite foot. When the feet are brought together, the arches add up to form a dome, a geometrical figure which is particularly effective at bearing weight. Any good arch has a keystone, a central segment at the peak of the arch that holds the other segments in place. The talus acts as the keystone of the medial longitudinal arch, and the cuboid is the keystone of the lateral longitudinal arch. The cuneiforms serve as keystones in the transverse arches. The arches of the foot are reinforced by ligaments and supported by tendons of active muscles. The main ligaments reinforcing the lateral longitudinal arch are the long plantar ligament, which runs from the calcaneus to the cuboid and to the bases of the second through fourth metatarsals, and the short plantar ligament, or the plantar calcaneo-cuboid ligament, which runs from the calcaneus to the cuboid. Keep anatomical position in mind when you hear this statement. The short plantar ligament overlies the long plantar ligament. However, if you're dissecting a foot in the laboratory, you'll reflect the long plantar ligament to access the short plantar ligament. You may recall from the solid anatomy lecture on the leg that the peroneus longus tendon crosses the lateral side of the foot and runs across the deep plantar surface to insert on the base of the first metatarsal. When this muscle is active, the tendon tightens and supports the lateral longitudinal arch. The medial longitudinal arch gets some support from the sustentaculum tali, an extension of the calcaneus that forms a shelf for the talus, which is also the Latin translation of its name. Sustentaculum means shelf. Providing additional support for the talus is a ligament running from the sustentaculum tali to the navicular, which is called the plantar calcaneo-navicular ligament, or more simply, the spring ligament. The tendon of the tibialis posterior also supports the medial longitudinal arch when this muscle is active. The tibialis posterior muscle originates in the posterior compartment of the leg. Its tendon passes the posterior side of the medial malleolus and crosses the medial edge of the foot to reach the plantar surface, where it has multiple insertions on tarsal and metatarsal bones. Degeneration of this tendon is said to be the most common cause of fallen arches or acquired flat foot deformity. Loss of the medial longitudinal arch usually results in pain during standing and/or locomotion. A prominent feature on the posterior end of the dorsum of the foot is the inferior extensor retinaculum, a Y-shaped, longitudinally oriented band formed by the thickening of the deep fascia. It holds the tendons of the extensor digitorum longus and extensor hallucis longus against the ankle as they cross the ankle from the anterior compartment of the leg to the dorsum of the foot to extend the digits. The inferior extensor retinaculum prevents these tendons from bowstringing, that is, rising up from the ankle when the muscles are contracted, and thereby improves the mechanical advantage of these tendons. If you are wondering where the superior extensor retinaculum is, it's on the distal end of the leg. There is also a flexor retinaculum at the level of the medial malleolus that holds the tendons of the flexor digitorum longus, flexor hallucis longus, and tibialis posterior against the ankle, and a peroneal retinaculum at the level of the lateral malleolus that holds the tendons of the peroneus longus and brevis in place. There is a muscle belly on the dorsum of the foot that originates on the calcaneus and splits into the extensor hallucis brevis, which inserts on the proximal phalanx of the hallux, and the extensor digitorum brevis, which divides into three tendons that insert on the tendons of the extensor digitorum longus running to the second, third, and fourth digits. The extensor hallucis brevis and extensor digitorum brevis are intrinsic muscles of the foot. That is, they originate and insert in the foot and do not cross the ankle joint. They extend the digits and are innervated by the deep peroneal nerve. The skin on the plantar surface of the foot is thick but sensitive and tightly connected to the underlying plantar aponeurosis by skin ligaments. The plantar aponeurosis is the central area of the deep fascia of the foot, which is composed of longitudinally arranged bundles of dense fibrous connective tissue. It is reminiscent of the palmar aponeurosis of the hand in its adherence to the skin and musculature on either side of it. The plantar aponeurosis protects and supports the foot. It arises from the calcaneus and spreads out to the digits, where it becomes continuous with the fibrous digital sheaths that enclose the digital flexor tendons.
All right, it's time for a clinical correlation. Now, I want to take a minute to point out a clinical situation that can occur with the plantar aponeurosis, which can also be called the plantar fascia. Now, this fascia can become inflamed, and then we refer to it as plantar fasciitis. Now, another common term for this condition is policeman's heel, but you probably won't hear that too often. Plantar fasciitis is a very common reason for heel pain, and in fact, plantar fasciitis is the most common cause of heel pain in adults. It's often caused by overuse of the plantar fascia. Now, the etiology is probably a degenerative tear of part of the fascial origin from the calcaneus. Onset of symptoms is usually insidious, not usually related to a fall or a twisting injury. Patients report focal pain and tenderness directly over the medial calcaneal tuberosity and 1 to 2 centimeters distally along that plantar fascia. Now, the pain is often described as being worse upon standing after being seated for a while. Or you'll hear this a lot, the first step of out of bed in the morning is the worst step of the day. Often considerable pressure must be applied to this area during the examination to reproduce that weight-bearing stress and then get that same pain from the patient. Patients may have tightness in the Achilles tendon as well, and passive dorsiflexion of the toes may cause increased pain. Radiographs are not necessary as part of the initial evaluation if that patient's history and examination are consistent with a diagnosis of plantar fasciitis. However, a heel spur or osteophyte develops in the origin of the flexor digitorum brevis, just superior to the plantar fascia in approximately 50% of patients with plantar fasciitis, which may be seen with an X-ray. It also can be the case where a spur can be present on the X-ray and the patient doesn't have any symptoms at all, so be aware of that. The majority of patients with plantar fasciitis can be managed satisfactorily with non-surgical treatment. Patients should be informed that it sometimes takes 6 to 12 months for these symptoms to resolve. Avid walkers and joggers should be counseled concerning alternative exercise regimens such as use of a stationary bike. Initial treatment should include over-the-counter orthotic device such as a silicone heel pad, along with a home program of stretching exercises. If symptoms persist despite attempts at these conservative management, then you can do an injection of corticosteroid into the heel. A formal physical therapy consultation may be necessary to help direct the patient's continued stretching program as well. Surgical treatment typically consists of partial release of the plantar fascia. Surgical release should be considered only after at least 6 or 12 months of really intense non-surgical management. All right, so that's enough about that. Let's go over some questions now. What is the most common cause of heel pain in adults? Hope you know it by now, plantar fasciitis. Next, what physical exam finding is suggestive of plantar fasciitis? So tenderness directly over the plantar medial calcaneal tuberosity and 1 to 2 centimeters distally along the plantar fascia. And remember, that's after someone's been sitting for a long time, they get up and start walking, or that first step of the day after getting out of bed is the worst step of the day. So remember that, very important. All right, guys, so it's time to get back to that lecture now.
The muscles on the plantar surface of the foot are divided into 4 layers from superficial to deep. The first layer is just deep to the plantar aponeurosis, which is especially adherent to the central muscle of this region, the flexor digitorum brevis. Medial and lateral to this muscle are the abductor hallucis and the abductor digiti minimi, respectively. All 3 of these muscles take their origin from the calcaneus. The flexor digitorum brevis gives rise to 4 tendons that bifurcate distally and insert on both sides of the middle phalanges of digits 2 through 5. The tendon to the 5th digit is often absent, however. The tendons of the flexor digitorum longus pass between the bifurcated tendons of the flexor digitorum brevis to insert on the distal phalanges of these same digits. The abductor hallucis inserts on the medial side of the base of the proximal phalanx of the hallux and moves this digit away from the midline of the foot. That is, it abducts it. Be aware that the midline, or the axis of the foot, is the second digit, meaning that abduction and adduction of the digits occur relative to the second digit. If you've watched the solid anatomy lecture on the hand, you may recall that the axis of the hand is the third digit. The abductor digiti minimi, or abductor digiti quinti, inserts on the lateral side of the base of the proximal phalanx of the fifth digit and abducts it. Two intrinsic muscles of the foot are found in the second layer of the plantar surface. Both of these muscles attach to the tendon of an extrinsic muscle of the foot, that is, a muscle that originates outside of the foot but inserts on the foot. These intrinsic muscles are the quadratus plantae, which originates on the calcaneus and inserts on the lateral edge of the tendon of the flexor digitorum longus, and the four lumbricals, which take their origin from the tendons of the flexor digitorum longus. The true function of the quadratus plantae is a matter of controversy, but it is commonly believed that it redirects the force of the obliquely oriented flexor digitorum longus tendon to bring it in line with the axis of the foot, so the digits are flexed rather than pulled medially by it. The four lumbricals originate from the individual tendons of the flexor digitorum longus muscle, extend anteriorly, cross the medial side of the second through fifth digits, and insert on the dorsal expansion of the digits. The lumbricals of the foot have the same action as they did in the hand. They flex the metatarsophalangeal joints, in the hand it's the metacarpophalangeal joints, and extend the interphalangeal joints. If you can't tabletop your toes, it just means you haven't been practicing, because you have the muscles necessary to do it. Unless you don't, which is possible, because one or more lumbricals are often absent from the foot. One study found that all four lumbricals were present in only 55% of the 257 feet that they studied. When muscles are reflected to reveal the third layer of the plantar surface of the right foot, a 7-11 configuration can be observed. In the left foot, it's the mirror image of a 7-11. The 7 is formed by the transverse and oblique heads of the adductor hallucis, and the 11 are the lateral and medial heads of the flexor hallucis brevis. The oblique head of the adductor hallucis originates on the bases of metatarsals 2 through 4. The transverse head originates on the plantar metatarsal ligaments, which connect the distal ends of the metatarsals. And both heads insert on the lateral side of the base of the proximal phalanx of the hallux. As you can tell from its name, this muscle was originally thought to be involved in adduction of the hallux, but many researchers remain unconvinced of its true function. The flexor hallucis brevis has bilateral heads running on either side of the tendon of the flexor hallucis longus. Both heads originate, often as a single muscle belly that bifurcates distally, on the cuboid and the lateral two cuneiforms, and insert on the base of the proximal phalanx of the hallux. A sesamoid bone is embedded in each of the insertion tendons of this muscle. These sesamoid bones have the same function as the patella in the knee. That is, they increase the lever arm of both heads of the flexor hallucis brevis, which increases the torque produced by this muscle. Hallux is derived from the Greek verb meaning to leap or to spring. And if you're using your hallux to leap, you're probably flexing it with the muscles that we just described. The other muscle of the third layer is the flexor digiti minimi, which is sometimes called the flexor digiti minimi brevis. It originates on the base of the fifth metatarsal and inserts on the base of the proximal phalanx of the fifth digit. It flexes the fifth digit. The 3 plantar and 4 dorsal interossei occupy the 4th layer of the plantar surface of the foot. The plantar interossei are found on the medial sides of the 3rd through 5th metatarsals, and the dorsal interossei are attached to both sides of all of the metatarsals. These muscles have the same action as their counterparts in the hand. So if you memorized the mnemonics dab and pad for the hand, you can apply them to the foot as well. Dorsal abduct, dab, plantar instead of palmar, adduct, pad. Remember that the 2nd digit is the axis about which adduction and abduction occur in the foot. By the way, the tendon of the peroneus longus is visible in the 4th layer of the plantar surface of the foot as well. Remember that this muscle originates in the lateral compartment of the leg and continues posterior to the lateral malleolus. It then crosses onto the plantar surface of the foot and inserts on the lateral side of the base of the 1st metatarsal. The lateral and medial plantar nerves provide motor and sensory innervation to the plantar surface of the foot. They are branches of the tibial nerve, which bifurcates after passing the posterior side of the medial malleolus and crossing onto the plantar surface of the foot. All of the muscles of the plantar surface of the foot are innervated by the lateral plantar nerve except for 4. These 4 exceptions, which are innervated by the medial plantar nerve, may be remembered by the mnemonic LAUGH. L for first lumbrical, A for abductor hallucis, F for flexor hallucis brevis, and F for flexor digitorum brevis. Don't be fooled. The dorsal interossei are not innervated by the deep peroneal nerve. They are innervated by the lateral plantar nerve. The medial and lateral plantar nerves are accompanied by the medial and lateral plantar arteries that arise by the bifurcation of the posterior tibial artery, which, as you may recall from the solid anatomy lecture on the leg, is a branch of the popliteal artery. The lateral plantar artery dives under the oblique head of the adductor hallucis and forms the lateral half of the plantar arch. This arch is completed by the dorsalis pedis artery, which is the continuation of the anterior tibial artery distal to the level of the malleoli. The dorsalis pedis artery travels anteriorly along the dorsum of the foot and dives between the 1st and 2nd metatarsals to join and complete the plantar arch. Medial and lateral plantar veins drain the plantar surface of the foot into the posterior tibial vein. The dorsal venous arch on the dorsum of the foot gives rise to the great saphenous vein medially and the lesser saphenous vein laterally. You may recall from the solid anatomy lecture on the leg that the sural nerve provides cutaneous innervation to the lateral 2/3 of the posterior side of the leg and the lateral 1/3 of the anterior side of the leg. It also provides cutaneous innervation to the skin over the heel of the foot. Cutaneous innervation to the plantar surface of the foot is provided mainly by the tibial nerve. It sends a calcaneal branch to the skin over the heel prior to dividing into the medial and lateral plantar nerves. The plantar nerves send cutaneous branches to most of the remainder of the plantar surface. The majority of the skin on the dorsum of the foot is innervated by the superficial peroneal nerve, except for a small patch of skin between the hallux and the 2nd digit, which is innervated by the deep peroneal nerve.
So that covers the foot. Now I want you to pause the video and answer the end of session quiz questions, and then we'll go through those answers together. All right, let's get going. Which bone of the foot articulates with the tibia and fibula of the lower leg? That's going to be the talus. Next, which artery becomes the dorsalis pedis artery when it crosses the extensor retinaculum? That's going to be the anterior tibial artery. Next, what four principal structures help maintain the arch of the foot? So we have the plantar aponeurosis, which we just talked about, plantar fascia, tendons of the tibialis posterior and anterior, tendon of the peroneus longus, and plantar calcaneonavicular, or sometimes referred to as the spring ligament. Next, do the intrinsic muscles of the foot flex or extend the digits? That's going to be extend. Next question. What is the innervation of the following muscles of the plantar surface of the foot? So we have the first lumbrical, abductor hallucis, flexor hallucis brevis, and flexor digitorum brevis. Now remember from the lecture, these are the muscles from the mnemonic LAFF, laugh. So lumbrical, abductor hallucis, flexor hallucis brevis, and flexor digitorum brevis. Now this is the medial plantar nerve, and this is providing innervation to these muscles. The rest of the plantar surface of the foot is provided by the lateral plantar nerve. Next, which main nerve innervates the intrinsic muscles of the feet? That's going to be the deep peroneal nerve. Okay guys, we're almost done. Now we've provided some images for you to label. Recalling these images in a time setting will help you perform well on the practical part of your examination. So label the images and then we'll be finished. Thanks.